we think will happen. And I think this is important because we need to get the public to appreciate that this is going through a process, and there are phases that we have gone through already, but there's still another phase to come, which we must prepare ourselves for. Can you, I hope you're seeing the slide on the screen. If not, I'm going to ask it to be put up, and then the CMO to just explain. CMO, turn your mic on.
Okay, so we now have 26 cases confirmed, and this includes, it's gone. Okay, thanks. All right, so we have 26 confirmed cases as of today. 18 of these are imported cases, one of which is a death that had occurred. We have 7 import-related cases and 1 that we're still investigating, a likely import-related case. So the imported cases are seen on the chart, and they have a diagram of an aeroplane in front of them to show that they came in when they came into the country. The cases that resulted from contact with them are seen in the large circles and in the blue. Can we point? No. Right, so the first case that we saw, the first case that we have 5 import-related cases. And for a case that we had that is numbered 4, we have 2 cases that are import-related from contact with that person. And then in the purple, we have 2 cases arising from another case. And we have 1 case, number 7, that you can see, 7.1. It's not in a circle, but you can see that 7.1, which is the last case that we confirmed, is related to the case in Clarendon. Now, so what we see on the previous slide were clusters of cases. Clusters meaning that you have cases that have arisen out of linkages to the imported cases. The WHO has described now 3 stages within the outbreak in terms of the type of transmission that is seen. The first stage is where we have no cases, and the second stage is where we have sporadic cases. Sporadic cases meaning that we would have had 1 or 2 imported cases and maybe a few cases that would have been linked to them. Cluster of cases is where we're seeing now that we can see definite linkages to the imported cases, and we're seeing more than 1 or 2 of these relationships. So right now we would have about 4 such clusters. Not large clusters, the largest being from our first case where we would have seen 5 confirmed cases related to that case. Now, the fact that we have these confirmed cases that are across the island and we have this cluster of cases, it suggests that there may be other cases that may have come into country that we may not be aware of. The next step is when we have community transmission, and community transmission is when these cases start to pop up within communities where we cannot identify the link to an imported case. Many persons may have come into country undetected by the surveillance system. They may have been in the communities, been in contact with other persons. These persons might have traveled to other areas. And so at the point of them presenting to a healthcare facility with symptoms suggestive of COVID and maybe tested positive, there is no definite link that we can trace to an imported case. Once we start seeing that, even if we see 1 or 2 cases, it means that this way of transmitting more than likely has happened across the country, and we would expect that we will be seeing more of these community cases that would be popping up across the country. And once we are seeing several of those cases, then we would say that we are community transmission. Community transmission is also defined by the fact if in our routine surveillance that we are doing now, we pick up many cases that are from the community who we cannot establish a link with imported case.
That's it? Okay. Thank you, Chief Medical Officer, Dr. Jacqueline Bisesa McKenzie. In terms of testing, we have now tested 150 samples. 26, of course, would have tested positive, 124 tested negative. 18 results are currently pending. In the meantime, 17 persons are under quarantine in a government facility, 142 are under quarantine at home, and 254 have been released. These, of course, do not include the quarantining arrangements at 7 to 8 miles Bull Bay and Corn Piece settlement. In terms of our hospital readiness, we continue to expand on our readiness to deal with any potential surge capacity, meaning increasing numbers for our critical hospitals. So including that, those are KPH, Port Antonio, Mandeville, Cornwall Regional, St. Anne's Bay, the University Hospital of West Indies, Bustamante Children, and National Chest. We are currently operating at an isolation capacity of some 150 across the island, but with the capability to accommodate up to 326 persons should the need arise. The last time we announced that we needed approximately 600 rooms to support the efforts at quarantining and isolation outside of the hospital setting. And we justified that on the basis of our projections, if we were to have, when we have community spread, and on the basis that the virus, even when one is asymptomatic, having recovered from the signs that are manifested when you have the virus is still active and could be active for a number of weeks. And so we needed to lodge those persons in a facility that would provide isolation boundaries, but not be a high intensity or an ICU unit. So we needed these rooms, if you will, accommodation that we were seeking to source external to our hospital setting. We have started that search, and we have had a number of offers. The suitability, however, of those facilities in a number of cases are a challenge. Either they're too small, or in some instances the costs are prohibitive or are high based on the private provider's requirement. And so the search continues. In 1 or 2 cases we think they are appropriate, and discussions are taking place. I want to make the point, I make the point as an update, but also to say that this type of accommodation that is required is absolutely critical to the plan to dealing with the community spread that is likely to come in a not too distant future. And we are going to have to make some hard decisions as it relates to the suitability of this space, to the extent that this space exists within the private sector. We are going to have to hopefully collaborate and get the willingness of those players to work with us in the public's interest, in the interest of all of us. And at the very last resort, if we're not getting that cooperation, then there's always the possibility of triggering the law under the emergency powers that exist under these conditions in the national interest to dictate a position that would see us having possession of some of these properties. I mean, that's not what we would like to do. There would have to be fair exchange in terms of market value if it were to come to that. But at the end of the day, we have to find the right blend and the right mix in order to deal with the cases that are likely to come from community spread. And I say that to encourage further discussions, to encourage further negotiations, and to encourage those who can play a role as part of this national response to what is a national threat, for us to hopefully reach an accommodation in the days ahead. I want to move on now to the issue of test kits, because we know that has been a big issue raised in several quarters, the rapid test kits, that is. Now, we have been doing tests in the traditional way, guided by the WHO PAHO training through the National Influenza Center at the University of the West Indies. And those tests have gone well. We have done a number of tests based on the clinical definition and recommendation as to who should get those tests. But there is a view that by many that we should have more testing sites and offer the tests in a more liberal way, indeed, for whomever wishes to have the test done. There are jurisdictions in the world that are doing that through the rapid test kits. There are some concerns around the accuracy of these kits. I had appointed a team to look at what is available out there, guided by WHO and PAHO, and make some recommendations as it relates to those kits. I'm going to ask the Chief Medical Officer just to comment briefly on the idea of our testing protocol and the role that these kits can play, and a sort of timeline at which we will hopefully make some decisions on that.
All right, thank you, Minister. I just want to speak a little bit about our testing protocol. So our testing protocol includes testing the following persons. Persons who meet the case definition of a suspected case. That is, those persons who would have had contact with a confirmed case of COVID-19 or would have traveled from an area where there is community transmission of COVID-19 and now presents with fever and respiratory symptoms. Or persons who meet the case definition of a person under investigation, meaning that they have the contact with a confirmed case or have traveled from an area where there is community transmission and have some symptoms. So they may not have fever and the acute respiratory symptoms, but they may have fever alone, or they may have respiratory symptoms alone. Those persons would be considered persons under investigation and would be tested as well. In terms of contacts are traced for all confirmed cases of COVID-19, and all the contacts are quarantined. They must remain at home and keep themselves away from others as much as possible. While they are without symptoms, the chances of them spreading the virus is very low. They are monitored closely to see when they develop symptoms, and all contacts who have symptoms at the time of finding them are tested. All asymptomatic contacts are monitored closely by the public health team through temperature and symptom logs that are done daily. As soon as they develop symptoms, they are tested. Testing of persons when they are without symptoms can result in a negative test even if they are incubating the virus. This gives a false sense of security and cannot replace the 14-day quarantine period. As the persons are being quarantined, then in terms of testing them, as soon as the symptoms develop, then we test them. The timing of testing at symptom onset is to allow for the best pickup for the virus. We have checked our protocol by conducting tests on close contacts. 13 tests were done for close contacts as soon as we detected those contacts, and they were all negative. These persons remain in quarantine and will be tested again if they develop symptoms. With regards to the general surveillance of the population to determine if there is community spread of the virus, the Ministry of Health and Wellness is doing tests on the following groups of persons who would not have had any contact with a confirmed or suspected COVID-19 case. All severe acute respiratory illnesses that are admitted to hospitals. Healthcare workers with influenza-like illnesses. A number of persons who present to the hospital emergency departments and health centers with influenza-like illnesses. This provides a network of sampling that covers all parishes and will allow us to detect if there is any community transmission of the disease. Up to present date, we have received so far materials to do about 3,000 tests from PAHO. In the event of a spike, our testing methodology changes, and this will, with the reagents that we presently have, it will allow us to double the number of tests that we are able to do. In either case, we therefore have 2 months' supply of testing material. We have requested from PAHO additional kits that we will receive within that time. The test using the National Influenza Center checks for the virus using a real-time reverse transcription polymerase chain reaction and is reliable, and it is crucial to have reliable test results for effective management of COVID-19. In addition to this, the Ministry of Health and Wellness is exploring the use of rapid test kits. Many of the rapid test kits that are being marketed now for COVID-19 detection use a technique that traces the antibody that are produced in the human body from the infection, and these antibodies appear later in the infection. These tests cannot be used for confirmation, and so therefore, while we are investigating these tests to see what their reliabilities are, we have to develop, and we are in the process of developing a protocol to say how it is that positive tests will be treated. So within the next few days, we expect that we will come to a consensus on the types of kits that we will use for these rapid tests and the protocol that we will use to conduct these tests. But in the meantime, I want to reassure the public that we do have enough test kits in place to conduct this surveillance as well as the testing of persons that are suspected cases.
Thank you very much. Thank you very much, CMO. I want to just move on to another important new development, which I think is of importance to elaborate on, and that is the issue of how we manage the numbers in our institutions, in our hospitals, in light of the community spread that we expect and the particular vulnerabilities of those persons with underlying conditions who are treated within our public health institution. The history, very short but nevertheless important history of the virus, tells us that the mortality rate, those who die from the illness, tend to be the older population, and more importantly, persons who have underlying conditions, cardiovascular disease, diabetes, hypertension, and so on. As a consequence, we are very mindful of the realities of community spread among that vulnerable population and have begun to address that situation, starting with our public health institutions, where many such persons congregate on a daily basis for treatment. We have taken a decision that in the coming weeks, we are going to engage the private sector under a public-private partnership arrangement, PPP, to outsource some of the services that are currently being carried out in our public health institutions, our hospitals in particular, to minimize, to reduce the numbers of the comorbid conditions or patients with those underlying conditions in our hospitals, and by extension reduce the health centers, and by extension reduce the risk of community spread within those health centers. We have decided to, under this arrangement, take out two highly vulnerable groups: persons who have chronic hypertension and persons who are diabetic. This number, based on our clinic sessions, numbers about 75,000 across the country, based on the database we have within our institutions. And the idea here is to outsource those two sessional visits by this population to private practitioners who will see them once or twice per month. And we want to do this for approximately 4 months in the first instance. What this will mean is that we will ask for proposals from private practitioners. We will advertise this to provide this service. We will coordinate with them once the process is complete and we identify a spread across the country to meet those persons who live within the respective parishes. An agreed rate for each person seen, and these persons would be directed to go to that particular private practitioner to get their regular checkup and prescription based on a registered arrangement under the National Health Fund, where they would have an NHF card and use that card to access the particular service. This is something that we've been thinking about for some time, to be totally frank, because we understand the crowding effect in our health centers across the country, and we have been trying to develop programs to bring the private sector into providing some of these services, thus reducing the crowding in our health centers. We have decided to fast track this because we believe it will play an important role in reducing the community spread risks within those health centers. We anticipate that this will cost us some $350 million over that period of time, and the details of this will be made public, but we're going to be embarking on that as soon as the next week or so. In terms of the community quarantining arrangements, I just want to raise with the public that the Bull Bay 7 and 8 mile arrangement, based on the clinical assessment of when it started and the time required to complete this process, in other words, to discontinue the quarantine arrangements in Bull Bay, the decision has been taken to complete that arrangement on Saturday, the 27th of March. And so to the residents, to the citizens of Bull Bay, we ask for their patience until end of day Friday, at which point we will resume normality in that community. As you know, the number of cases that we have had in that community justified the need for the quarantining arrangements based on the links to patient 1. And we want to thank the citizens, the residents, for their understanding, and of course the respective agencies, starting with the health authorities, the constabulary, the JDF, for providing critical support during these times. But we still have a few days to go, and we ask for your patience in that regard. I'm not sure if the Chief Medical Officer wants to add anything to the Bull Bay arrangement.
Yes, Minister. I would just want to say that in the next few days, 2 to 3 days, the Public Health Department would be ensuring that they do final checks on the persons that would have been identified as close contacts or casual contacts to make sure that they have not developed any symptoms. Anybody that would have developed symptoms would have to be treated differently. So while it is that we do end the quarantine period on Saturday, if there are persons who would have developed symptoms, then around that person, there may be different arrangements that would be made.
Thank you. As it relates to the current piece, Southeast Clarendon quarantine arrangements, it continues as is. The health authorities are on the ground. The supporting infrastructure, the Ministry of Labour and Social Security, the Constabulary, the JDF providing critical support. We have so far linked one case to the index case in that community. That person who is now deceased had links to our 26th confirmatory case. And again, that demonstrates that what we're doing, we think, is correct. We continue to carry out the necessary surveillance. And again, I extend our appreciation to the residents of that community and ask for their patience as we seek to manage this process. I want to close and then open for questioning on a particular note, unless any of my colleagues have anything to add. And that is that as we discover these additional cases, it's important for us to appreciate as a country that these are expected under the existing circumstances. And I don't want the Jamaican people to lose hope or to feel that we are not making progress even with each positive case that is identified. Indeed, if you look at the process or the phases of the virus, moving from imported to clustering, and then what we think will be community spread, it means that you will see more cases with each phase. And what we're trying to do is to manage the process in a way that minimizes the numbers that we see, even though that still equates to more cases being discovered under the community spread arrangement. And there's an important distinction between clustering and community spread. And that important distinction is just the sheer numbers that you're likely to see. Because the simple definition for community spread is that we are going to see persons having cases and cannot trace those cases to anyone, which makes it difficult to trace and to determine who may be vulnerable or who may not be vulnerable. And so you could have 10 cases popping up at any point, at anywhere, and it could grow and become exponentially higher than what we're experiencing now. We are doing well under the circumstances when compared to other jurisdictions, and I want to commend the health team for the work that they're doing, and the government for the support, and all of Jamaica, frankly speaking. However, community spread should not allow us to panic, even though we are likely to see a lot more cases. What it should do is to allow us to be more concerned, yes, and to take the necessary precaution to manage through to its completion as quickly as possible. In other words, to flatten the curve. And that's what we're trying to do, as opposed to what we see in other jurisdictions with significant numbers and by extension deaths from that. We will comment more on that as the days commence, but I want to just outline that because I think it's important that the public appreciates why we have to do what we have to do, why the Honorable Prime Minister has had to announce further restrictions, and why he said, if necessary, there may even be more restrictions to come. Because again, I say, the most effective response to the coronavirus is to minimize person-to-person contact. And there are some of us who I believe are not taking it as seriously as we should. There are others who are. The restrictions that we impose, or that the government imposes on the emergency powers, is intended to flatten that curve so we can get over this hump and resume normality as soon as possible. And I crave your support for that. I made an error when I said the quarantine of 7 and 8 Mile would close on the 27th. Saturday, it's really the 28th, right? So it's actually the 28th, Saturday the 28th, not the 27th. Okay, we're open now for questions. Stephen, you want to guide that process for us?
Okay, thank you, Minister. So again, we're inviting members who are on the Zoom link to raise their hand so they can be identified, and then we'll ask the question. We have a question from Dion Jackson Miller. She's asking, we heard that 30 health professionals at KPH were being fitted for masks. Is that all there will be? What is happening with the mask fittings, not just at KPH, but elsewhere?
Okay, thank you for that question. So we have been doing mask fitting across several hospitals over the last couple of days. And so far we have been to the Kingston Public Hospital, University Hospital of the West Indies, Bustamante Hospital for Children, St. Anne's Bay Hospital, Mandeville Regional Hospital, Victoria Jubilee Hospital, Cornwall Regional Hospital, Princess Margaret Hospital, Spanish Town Hospital, National Chest Hospital, Savlamar Public General Hospital. We've also done the Kingston and St. Andrew Health Department, St. Anne's Bay Health Department, Western Region, Westmoreland Health Department, Mandeville Health Department, St. Catherine Health Department. We've also done the Falmouth Public General Hospital, St. Joseph's Hospital, Trelawney Health Department, and Hanover Health Department. Persons from those facilities have been tested. Now, in terms of the numbers that have been tested and have fitted, so we have tested and fitted 284 persons. In addition to this number, these were numbers that were done by the Ministry of Health staff. But in addition to that, we know that the regional health authorities have been doing their own fit testing, and we know that additional 60 persons were done at the Spanish Town Hospital, and additional 60 persons are supposed to be done at the Kingston Public Hospital, Bustamante Children's Hospital, and the National Chest Hospital. Not sure about the 60 for National Chest Hospital. But we are moving to do first the persons that will be associated with critical care management, where we know that the N95 mask will be needed, and also for the persons that are going to be doing the testing of persons. And that's why you will see that some persons from the health departments have also been fitted. So we know that there are quite a lot of other persons that need to be fitted, and we are moving steadfastly to try to cover as much ground as we can in a short as possible period.
Thank you, CMO. We're going to go to Albert Ferguson. Albert?
He's unmuted.
Albert, you can go ahead with your question. All right, we're going to take another one on Twitter. Someone's asking, was the new case found in the community under quarantine in Clarendon?
Right. So the person came from the community of Cornpeace, but the person was being monitored through the monitoring of contacts that the health department does, was discovered to be symptomatic, and was taken to the Maypen Hospital, where he was isolated and was tested and found to be positive. So he remains in hospital.
Thanks, CMO. We have a question here from David Casson, from Debian Wright, actually. Said yesterday the Prime Minister was asked in Parliament about the health and life insurance for doctors dealing with coronavirus cases. He said the Health Minister would be able to give an update on the talks in relation to that. Can he say whether any decision has been taken?
I can't give any specifics to that right now, to be totally frank. But I will certainly get some better particulars and get back. We have these press briefings quite frequently, so I promise at the next one I'll give better details.
All right, thank you. Still giving Albert a chance to ask his question if he can hear us. All right, we have a question from Michael Sharp.
I'd like to find out what arrangements are being made to bring home some of the workers that are, I think some 29 of them that are stranded in Florida.
I don't have a lot of details on that at this point in time, but I know we work closely with the Ministry of Foreign Affairs and Foreign Trade and the Ministry of, are these farm workers? Okay, so if they're farm workers, Michael, the Ministry of Labor and Social Security would be driving that process. So I will have to find out from them exactly what arrangements were made. I know in the past, over the last couple of days, we have had almost 400 farm workers being transported back into the island, having completed their term of contract. So I'm not totally clear on this 29 that you refer to, but they would be the ones who would coordinate that.
Thanks, Minister. We have the question now from Albert. He says, how many of the 600 rooms needed to house recovering COVID-19 patients in isolations have you signed off on based on offers from the private sector?
Okay, so I'm looking at a report that I got just minutes before coming in, and we really have not signed off. Well, let me not say we have not, because we have a facility in Montego Bay which is about 50 rooms offered to us by a hotelier, which we are now retrofitting, which will suit the purposes that we are anticipating for the 600 room. We have offers that I'm looking at here, which would total a number of rooms, but again, it's quite fragmented, offering 10 or 15 rooms. There are many restrictions for health workers as opposed to persons who are positive and in transition. And of course, there are differences as it relates to the cost of these rooms. I wanted to go this route first, which is to invite persons to offer, given that economic activity is relatively limited, certainly in the tourism industry, and this could be an opportunity to continue some levels of operation and keep some workers engaged while we respond to the health challenge that we have. Beyond that, we will have to, if we do not find suitable facilities, we will have to identify what represents a suitable facility and engage those persons or institutions to use those facilities. As I said earlier, I was trying to be as diplomatic as possible. I'm not in the habit, or my philosophical approach or ideological approach is not to promote taking over private property without an agreement on all sides. But the reality of the situation is that this is a public health crisis, that we are all at risks, and we all have to find a way to contribute, if necessary, to solving that problem. Now, that's a roundabout way of answering the question. The answer to your question is we still have a fairly long way to go in identifying those 600 rooms. It's not just about the rooms, it's also about where they're located, because we want to place them strategically so access, depending on where persons are, can be relatively easy, and that the management or manning of these facilities can also be efficient. So over the next few days, we'll be doing more to try and identify what is suitable, and we will have to engage in appropriate discussions with those persons to ensure that that is in place, because this is fundamental to the response plan that we have, particularly when we go into community spread, which we believe is going to happen sooner rather than later.
All right, thanks, Minister. We're going to go to David Casanova. You can go ahead with your question. And please just identify with Media House you represent.
David Casanova, Love Television. My question is, why can't persons be tested arbitrarily?
Okay. All right. A test at random, I'm assuming this means that you just want to know if you have COVID. It does not really give you a lot of information, because if it is that you are negative, if you have been exposed, you might be incubating the virus. And it gives you a false sense of security that you are COVID-free, when in fact 2 to 3 days later, you may start developing symptoms and probably would have to be tested again to find out if this is COVID now. So it really is a matter of looking at resources that are available to ensure. I mean, we do expect that we're going to see a spike in the number of cases. And we want to ensure that the resources that we have will be able to take us through to test for the persons that are symptomatic. So at this point, persons just walking in to find out if it is that they are positive. If they are positive and they are asymptomatic, it still means that they're going to have to stay at home. If they are positive and they're having mild symptoms, they still have to stay at home. If it is that they're negative, it does not mean that they don't have COVID. So if they think they have a contact, or if they think they have some kind of a symptom, they still have to stay at home. So our message really is that if it is that you have mild symptoms, then you should stay home. It may be COVID, so you need to stay home, protect yourself, protect your family, and stop the transmission. If it is that you do not have symptoms, but you think that you may have contacted somebody who may have had symptoms, then you need to stay home. If you develop symptoms, then if they're mild symptoms, you stay at home and you treat with medication for the fever, and we recommend that you use Panadol for that treatment. So the main message is really staying at home. Call the hotlines, and I'm encouraging persons. I know that there are some gaps that we need to fix where the hotlines are concerned, and we are working on that. But call the hotline so that at least we have you on a list, so that if it is that you are suggestive, highly suggestive of COVID, that we can be following you up on a daily basis. Or if it is that you are at a high risk or a vulnerable person based on any kind of immunocompromised situation, then we're able to follow you up to see if and when you do develop symptoms, if those symptoms become moderate to severe that you need hospitalization, then we can get you into a facility that you can be treated.
I just got some information just before your next question on the fit testing schedule. I think a question was asked by RJR's Dion Jackson Miller. Re-KPH and Victoria Jubilee. Thursday, the 26th of March, 100 to be done, 50-50 on either side of both hospitals. March 27th, 54 Bustamante Hospital for Children, 44 National Chest Hospital. And the information is that testing is ongoing, so more will happen and more have happened in the past. So the process continues as we prepare.
Thank you, Minister. We have a question on Twitter. I'm going to ask Dr. Webster to respond. The persons are asking about patient 1 and 2 and their status.
Thank you. Patients 1 and 2 are asymptomatic or they're without symptoms for a few days. There are 3 patients currently who are asymptomatic in the group, and their course was between 4 to 6 days, on average 5. And so they are asymptomatic, but for them to be discharged, they would have to show that their swabs are negative. So far, these persons are failing on their discharge swabs. So they are still shedding the virus. And hence may transmit it to others. So this is why they're still in hospital.
All right, thank you, CMO. We're going to go to a follow-up from Michael Sharp. Michael, go ahead, please.
Yes, thank you. Just to let you know, sir, it's the hospitality workers, not the farm workers. But secondly, though, cutting down that curve, should we continue on the trajectory and good management, and congratulations and kudos to the team. However, if our neighbors and if our big neighbor is not cutting down their curve, does not that delay us from joining and getting back with normal life?
Thank you, Michael. You are right. Firstly, the prospects for recovery as it relates to Jamaica are heavily linked to what entails elsewhere in the world, and particularly what entails as it relates to our closest partners, both our economic partners, places where many of our relatives and friends reside. The reality is that we want to protect our population, and so we will do what is necessary, as we are now doing. But we are also part of an interconnected world, which means we are codependent on each other. And so to the extent that other countries, the United States, for example, which is our main trading partner, may have restrictions within their own country as they attempt to overcome this challenge, would also impact us as it relates to our resuming normal activity. I would say, however, that for us here, our obligation is to ensure that the public health threat that is now a challenge for us within our population and within our borders is our absolute priority. And what we want to do is to overcome that threat as quickly as possible, and so resume a sort of normal sense of feeling secure as Jamaicans within Jamaica. And if we do that and then have to wait on others, and that's a choice that we have not many options in so doing, but at least our own population will feel safe. And so our priority right now is the public health interest. And as you can see, it's an all-of-government approach, and we're doing what we can on the economic front to give support while we work to overcome this threat that is challenging our normal life here in Jamaica.
All right, thank you very much, Minister. I have another question. They're asking for persons who are, if they should be practicing social distancing at home, particularly if you are a younger person living with seniors and you may be coming off the road and back into the home. How should you practice social distancing at home? I'm going to ask Dr. Webster to respond.
Yes, thank you for that question. So we'd like to say physical distancing, because our older persons, we have to socialize with them. But yes, if you're coming home from work, we would want you to make sure you wash your hands before you interact with your older relatives, or if you're a caregiver, and ensure that you ensure proper sanitation. And as if you are ill, then you do not interact with the older persons, and you get somebody else to look after them. So we would want you to pay special attention to your older relatives or persons who are in your care, and ensure that you do not go to work, do not interact with the older persons if you're ill, and decrease the amount of contact time with them. You can interact with them from a distance, however, to ensure that you are socializing with them, but not in their physical space.
All right, thanks very much, Dr. Webster. We have a follow-up from Dion. She said she spoke with the CEO of Andrews Hospital, who said they do not have the PPEs for their staff or ventilators, which is why they can't treat COVID patients. The minister on Monday had indicated that there would be some discussion. They're asking now for an update.
Okay, so just to say that that discussion has taken place. The permanent secretary had a lengthy conversation with the management of the institution. I've since subsequently spoken to him, got a brief, as well as to other critical stakeholders who are linked to the hospital. As you know, it's a church hospital. The Seventh-day Adventist Church owns and operates the facility. The end of that conversation, there was an agreement for a proposal to be submitted, which would included in that an explanation of some of the shortcomings of the institution, and we will take the necessary steps to discuss how we can get that hospital as a critical part of the response to the challenges we face. We really do need all hands on deck, and therefore we will do what we can to ensure that we get the hospital as part of the response infrastructure.
Right. I just want to say that in terms of critical care spaces, we would be concentrating on equipping the hospitals that would have the necessary facilities in place, because the high dependency space or intensive care space requires much more than the ventilator and the bed. It requires the staff to be in place, as well as the facilities for laboratory support. So we have to ensure that, and what we are moving to do is to ensure that our hospitals that are equipped to provide this kind of intensive and high dependency care receive the necessary equipment to do that. And in that light, I want to just mention that we have received 3 additional ventilators this week. And within another 3 weeks, we are getting an additional 7. And then in early May, we're getting an additional 20. So those ventilators are slated for delivery at those times.
Thank you very much. We're about wrapping up in about 5 minutes or so. We'll take a couple more questions. Damien Mitchell from the Gleaner is asking, is there anyone else from Cornpeace Clarendon who has piqued the interest of the health authorities? And he's also asking for Minister, is the government considering further restrictions on movement?
Well, all the persons within Cornpeace district who would have been contacts are being closely followed up at this present time by the Public Health Department. But in terms of development of symptoms, up to today, I have not been notified of any other person outside of the one person that was confirmed.
As it relates to the the possibility of more restrictions, this is a very fluid situation, and I think we've said that over and over. The response so far has been measured to the assessment of the risks and what we considered to be, at the time, needed to be done to minimize that risks, while at the same time managing our economic realities, and not just on a collective basis as a country, but as individuals, many of whom have very short earning cycles, limited disposable income, and therefore if they don't work, it becomes very difficult for them. And of course, industry that has to respond to the needs or the basic needs across the country. So we've had to balance those critical variables. Having said that, the Prime Minister and the Cabinet are very clear in their minds, and as a participant of those conversations, we're very clear that if we have to make other decisions that are more stringent, that are more restrictive, then those decisions are going to have to be made. One of the ways to manage the extent of those restrictions under law is the extent to which the public understands and appreciates the severity of the challenge and the need for personal responsibility to take the necessary precautions to protect themselves, their families, their communities, and by extension, the country. And while we believe that many Jamaicans are very seized with the importance of doing this, we are concerned, frankly speaking, that there are some Jamaicans who who are still not observing the social distancing, the need to stay at home, minimize the sort of public gatherings. And if that observation becomes the norm rather than the exception, and the risks for community spread becomes greater or becomes a reality, then I believe that the Prime Minister, who is on record of saying so, and the Cabinet would have no difficulty in increasing the restrictions. And I do believe that that could be a possibility going to in the future, but again, it would be subject to an assessment. I should add that this digital press briefing that we're having here, which I'm told is probably the first in Jamaica, has, as it relates to numbers in the room, exactly 10 persons. Okay? 10 of us in the room at the ministry. So we're actually complying with the 10 maximum congregation. It might be a minor point, but nevertheless I make it for whatever it's worth, because we really want to lead by example. And if you notice, we have 3 of us at this table, and I'm stretching out to try and touch the chief medical officer or the epidemiologist, and it's impossible, because we're trying to do the same as it relates to social distancing. I know it's a difficult task. We are, let me be frank and parochial, we are a touchy-feely population. We like to enjoy ourselves, we like to mingle and mix, but the realities of this virus is that we need to avoid that. And I really want to appeal to the population. It is a lot more serious than some of us take it. You only need to go on network TV to see what's happening in places like New York, worse to see what's happening in Italy and other parts of Europe. We really do not want that to happen to us here in Jamaica, because a lot of us will be left crying and regretful. So let's try to practice prevention, even while we prepare to deal with the cure.
Thanks, Minister. We're going to take our final questions now. We have a question from Emma Lewis. Emma, you can go ahead with the question.
Okay, I think this has been partially answered, but I want to know how many ventilators in total are we expecting to have, say, in the next 2 or 3 weeks on the island?
In the next 2 or 3 weeks, it would be about 10, and then early May we're expecting an additional 20.
Final question from Shanik Dawkins. He says there's an ad in the Sunday paper with the Ministry of Health and Wellness seeking to engage retired nurses and retired health educators in response to the coronavirus. How does the ministry plan on engaging these retired professionals when some of them would be at the increased risk due to their age?
I didn't get that. Can you repeat that question? Sorry.
Sure. An ad in the Sunday paper by the Ministry of Health and Wellness seeking to engage retired nurses and retired health educators in the response to the coronavirus. How does the ministry plan on engaging these retired professionals when some of them would be at an increased risk due to their age?
Okay.
What? You want to go ahead?
Okay. Right. So we're certainly aware of the risk that are faced by some of our persons that work as healthcare providers. In terms of the retired persons, they not only bring their clinical skills, but they also bring their administrative skills and their wide areas of experience. Many of them would have experience in public health. So we don't expect that persons are necessarily going to be clinically engaged, but we expect that certainly in administration and in supervision, which is really needed at this time, that we can utilize some of these persons, which would allow the younger persons to be able to be more clinically used.
All right, thank you very much. I'm going to ask the Minister just to give us closing remarks.
Thank you very much, Stephen, and thank to all those who are online. Thanks to the production team here, and of course to the clinical team, both at the table and otherwise. Ladies and gentlemen, I want to thank you for listening, and to the media, my media colleagues, for sharing the information that you would have received. This is part of our ongoing update. Our commitment is to be as transparent as possible with information around this issue, because we are convinced that it is in understanding the threat and the challenges and what you must do to protect yourself that we will overcome this issue as quickly as possible. The regular media briefs will continue, and we will use this based on the feedback as part of that information flow. If we do not have a live brief, then we will send out once a day an updated release, if you will, or a briefing to indicate exactly what has transpired over the previous 24 hours. And we will do this until we feel we have a handle on the situation, and the public's need to know on a daily basis is not as important as it is now. Thank you very much. Let's continue to do what we have to do. Remember social distancing. Remember to look out for your brothers and sisters and friends, and let us work together to overcome COVID-19. Thank you.
Flu and coronavirus can kill. Let's protect each other. A message from the Ministry of Health and Wellness. Reduce your risk of viral illnesses like the flu and coronavirus. Wash your hands frequently with soap and water. Cover your nose and mouth when coughing with a tissue and dispose of it. Avoid close contact with anyone with a cold or flu-like symptoms. If you become ill, please visit your doctor or the nearest health center and share your travel history. The flu and coronavirus can kill. Let's protect each other. A message from the Ministry of Health and Wellness. Reduce